Okay. Hi, everyone. Happy Valentine's Day. Happy Love Day. Welcome to the fourth lecture for Intro to Movement Neuroscience. I just wanted to quickly go over the midterm, talk to you and get your feedback as to how you felt about it. I was talking before the recording with some of the students in the group chat, and everyone found it fair, which is ideally what I would want from it. The questions for the next midterm and the final will be in much the similar fashion as the first midterm, so it's great that you had that experience. And any other comments or concerns? Oh, Sonia's asking if the quizzes close. They're supposed to close at the beginning of the lecture, but I just put it for 2 in case people come in late. How did you find? I asked this as well. How did you all find the tutorials? Was it nice to sort of have an interaction with someone about the material? It's about just like case studies, trying to clinically apply what you're learning, because I find if you can think about the topics of what we're learning in lecture in sort of a real life scenario, it sort of would add to or help build on your comprehension of neuroscience in the course itself. Yeah, exactly, Hannah. Karen's asking a question about, I don't know that question. No, it's lateral or none of the above because it's like things fine. I don't remember the question. Is this from tutorial? Oh, okay. You can review. So for all of you, if you email your TA, you can review your midterm with them. I don't have the. I think it was medial because it was the. So Karen's asking about the question about the motor homunculus and the car accident. I don't recall the question itself, but if it was foot, then it would be medial side because the foot wraps around in the medial side of the homunculus. Yeah. What area to say? I don't remember. I don't remember the question. Does anyone remember it? Yeah, so if it was foot or toe, where on the homunculus was the toe located? Or like the lower limb? What area? Yeah, it's on the medial aspect. So that's why. I don't remember if it was asking sensory or motor. If it was motor, that's pre-central. If it's sensory, that's post-central. So, okay. Was it sensory? Then yeah, then there you go. So then we post. Because remember, the central sulcus is the division between sensory and motor, sensory posterior or post, and then motor is anterior or pre. If it was sensory, yeah. Any other questions? Today's lecture shouldn't be too involved, just as we've reiterated this whole idea of synaptic potentials in the previous lecture and discussed summation, which was in fact the question, the short answer question on the midterm. Today, we're going to be discussing the actual synapse, so where the signal gets transferred from one neuron to another neuron or one neuron to another cell. Was there any questions about the asynchronous portion? So now do we understand this whole concept of how potentially we could consider neurons as integrating information? Because through the process of summation, which can happen either spatially or temporally, you're having those postsynaptic local potentials, either hyperpolarizing or depolarizing or being inhibitory or excitatory. They're all adding up together and then cumulatively figuring out whether or not they reach the threshold potential that will cause an action potential. So all of the local potentials add up and potentially could generate an all or none response, which is the action potential. So just to review, this was temporal summation, spatial summation, and they lead to the potentially build-up of polarization to lead to an action potential in the neuron. Is everyone okay with the whole idea of general summation? If we have receptor potentials, where would those occur? Yep. And on which type of neuron? Sensory neurons, yeah. So what we're going to notice is that there's a lot of terms that all mean sort of the same thing, right? So local potentials are all of them. Receptor potentials are ones that are postsynaptic potentials on the sensory neurons. The next ones in line are going to be synaptic potentials because they are generated through the binding of a neurotransmitter. That's on the inner neurons and the motor neurons. And all of those local potentials, whether they be synaptic or receptor potentials, can be either excitatory or inhibitory. Do we all understand that? That depending on the ion channel that they respond to or allow for diffusion, it could be either a positive or negative ion. So it can either hyperpolarize or depolarize locally the cell membrane. Yeah, exactly. So then what we have at the dendrites is an accumulation or adding up or summation of all of these either excitatory or inhibitory potentials. So you have a lot of input, either causing excitation or inhibition, and depending on how much of each there are, we have general summation that adds up, and if it ever reaches a negative 55 millivolts, we get an action potential. Is everyone cool with that? Awesome. That's great. So now let's talk about what's involved or the actual protein that's involved in this transmission of the electrical signal. It happens through the synapse, through chemical synaptic potentials, or chemical synaptic transmission, meaning the action potential goes to the presynaptic terminals of one neuron, and then that will cause the release of neurotransmitters into the synaptic cleft. The synaptic cleft is the space between the neuron and the next neuron or the next cell, muscle cell, or gland. And what happens is the neurotransmitter floats across and then binds with the receptors on that next cell. So we can have either neurotransmitters or neuromodulators involved in chemical synaptic transmission. They're going to be described based on the location of where they're being released. So Joseph has a question. Can the three modes of receptor activation occur for neuromodulators as well? Yeah, it all depends on how they're binding. And so we'll get into that. But if we had a neurotransmitter, that means that the protein being released is being released into the synaptic cleft. Whereas if we have a neuromodulator, that protein is going to be released into the extracellular fluid. So here we can see the difference. Same process. Here we have the presynaptic terminal of one neuron. And then what would have happened? The action potential would have caused the opening of calcium channels, which really causes the migration of the neurotransmitters to the cell membrane. And that here, the example of glutamate, would this be a neurotransmitter or a neuromodulator? Yep. So this would be a neurotransmitter. Neuromodulator is being released into the extracellular fluid, Karen. So see the difference? This is into the synaptic cleft. This is into extracellular fluid. This counts as the synaptic cleft. Yeah, I figured you thought I did. Nope. Yeah. So these proteins can be either a neurotransmitter or a neuromodulator. It just depends on where they're being released. And the neurotransmitters or neuromodulators are being named on the receptors that they interact with. And so Joseph was asking a question as to, are the 3 modes of activation specific to, I forget what the question was. You're asking whether or not there can be 3 types. I would think of it, so he was asking about the 3 different types of activation. Yeah, right, so that's just going to be based on what happens with the binding. So those are the 3, regardless of whether or not it's a neurotransmitter or neuromodulator, which in some cases is the same thing. Those 3 different modes of activation are just what can happen. So they could all 3 could happen with either neurotransmitter or neuromodulator. When the proteins bind, they can happen either directly or indirectly. Okay? Directly means that when you have the protein binding, it's binding specifically to a channel. So there's a one-to-one relationship where you have binding of the neurotransmitter or neuromodulator causes the opening of a channel. So it's called direct activation. Ultimately, what you want is you want the movement of ions as a result of the binding of the neurotransmitter. So it's called direct activation because the binding of the protein is directly opening the channel. So it's called direct. That's also called ionotropic because opening of channels causes the movement of ions. So ionotropic, moves ions. Indirect is when you have the binding of the neurotransmitter or neuromodulator, and it causes the release of a protein. That protein can go on and can open channels or do other things, but it's an indirect activation because it's not directly activating a channel. It's causing the release of a protein. GPCRs, what's that, Carl? Where'd you see that? Oh, yeah. Oh, you guys are just reading ahead, and so you're all doing the Joe show, eh? Okay, I like it. Respect. It's exactly true, Hannah. And so I guess now that you guys have all read ahead, I'm super impressed. But why would it be beneficial for the body to do that? Why would it need multiple modes of activation? Why would it need fast or slow acting? Yep, longer response. So it needs, because remember, action potentials are an all or none response, right? So by having different types of activation, it allows for slow or faster acting activation, and then also allows for receptor kinases. So it allows for protein transcription or other things to happen within the cell. So it just needs different types of activations. So if we had a ionotropic or direct acting activation, so remember we're talking about the synapse now. So when there's a release of our neurotransmitter, if it binds directly with the channel, that takes about 1,000th of a second. So the action potential is real fast, like so 120 meters per second. right? The rate limiting step, or like sort of the bottleneck, is that synaptic transmission, right? It slows down, but that still takes about 1,000th of a second to have the neurotransmitter release, float over, bind with the receptor, and the channel to open. That's a fast acting response. So that's why the direct activations are called fast acting, because they happen so quickly. Slow acting are when you have the neurotransmitter being released and it binds with a receptor, but that causes the release of a protein. That protein would go into the postsynaptic cell and then activate channels further along. So it would rather than having the neurotransmitter opening the channel, you have the neurotransmitter binding to the receptor, a protein being released into the cell, and then that protein would interact with multiple channels. So in this case, you have one neurotransmitter, one receptor. In this case, you could potentially have one neurotransmitter releasing one protein interacting with 10 receptors. So this is a slow acting relationship because it takes more time. However, it creates a much more profound effect. Not really like that, Shane. Because that's how it, I know. But it's okay. Just because it's like the words, like the Latin word is metabolism. It has to be metabolized. Yeah. So Hannah's talking about, so exactly. So the G protein, yeah, what else I want to show you guys. So do we understand the difference between fast acting and slow acting? So this is fast, this is slow, but can create a much more profound effect. So then you have two different options of how you want the neurotransmitter to affect the postsynaptic cell. So Karen, we were talking about neuromodulators. So when the protein acts as a neurotransmitter, it was either 1,000th of a second or 1/10 of a second in terms of speed. Imagine if you had the protein being released into the extracellular space. It can float around and interact with a multitude of other neurons. So then it can be an even more profound effect. However, the effect would take much longer to manifest. Yes, for sure, it has to do with urgency. Sometimes you need a small but quick response. Sometimes you need a medium response. Sometimes you need a very slow but very profound response. And so with just the release of the neurotransmitter or neuromodulator, this is how we can have three different options occurring. So look at the effect of neuromodulators. These effects can last from minutes to days. So an example of a neurotransmitter slash neuromodulator is substance P. So substance P is a very common neurotransmitter involved in the pain neurons, so the sensation of pain. It can also be released into the extracellular space as a neuromodulator, and then it interacts with a bunch of different neurons around in the extracellular fluid. So substance P is something that is implicated in pain syndromes because its use as a neuromodulator sensitizes the area. So in a lot of pain syndromes like fibromyalgia or chronic pain, you have a buildup of substance P, not acting as a neurotransmitter, but interacting with neurons up the chain of the pain system, or even in the reticular formation, and it sensitizes the area. So you tell me, Joseph. Joseph wants to know if substance P would act metabically. Yes, it would. In this case, when it's being used as a neuromodulator, it would be. And then, so Karen's asking about fibromyalgia. Does everyone know fibromyalgia or know what it is? Anyone? Yeah, sensitivity to pain. Okay, so fibromyalgia is sort of a pain condition in which the patient has a sensitivity to pain. So if you have normal touch sensation, in fibromyalgia, the whole body is generally sensitive to pain. So that pressure will be perceived as pain. And that is as a result of substance P neuromodulating the system to be sensitive to pain. So has anyone ever gotten like a cut on their skin, and if you touch the area around the cut, that skin is painful, even though that skin wasn't touched, the whole area is sensitive. Can we all agree on that? So that's an example of neuromodulation. So substance P is being released and interacting with all of the different neurons in the area to make them more sensitive. So now they are all going to be depolarized a little bit and more sensitive, right? Their local potentials now can add up more quicker. Well, so Carl's saying he thought it was just due to the inflammation, but that's what happens. It is due to the inflammation. The injury, the inflammation is causing substance P to be released as a neuromodulator into the area. So now it's desensitized all of the neurons. So now think of with a pain syndrome, that's just not an acute cut. That's happened at the spinal cord and brain level where the whole body is sensitive to pain. Yeah, complex regional pain syndrome is similar. Pain syndrome. Pain syndromes are all, that's why if you look at your pain syndromes, they're all similar mechanisms. Complex regional pain syndrome, you'll have a lot of sympathetic reaction as well. Hope I'm not confusing you guys. I feel like I'm going a lot off topic, but to answering your questions. But I like it as long as you all are okay with me answering questions. Is there a link between systemic inflammation and this dysfunction? Yeah, that's exactly what happens, right? So not only is the area sensitive, it also affects the way that the motor system outputs as well. Yes, and so Karen is saying that's how, because remember I said that how there's so many interneurons, right? It's through all those connections that now you have everything being linked to everything. And that's how the neurological system works. How you can have one little effect cause such a profound reaction as a result of the connections. Yes. So, remember we were talking about the three different sort of activations that can occur as the result of a neurotransmitter binding with its receptor. So the type of activation is going to be based on the receptor itself. So you can have one neurotransmitter being able to activate a bunch of different receptors. The activation mode that's going to occur is based on the receptor, not the neurotransmitter. And we'll go through different examples of why that is. Like just to have, for example, if you have epinephrine being released, it will upregulate the sympathetic neurons and then downregulate the parasympathetic neurons. It's not two different neurotransmitters. It's one neurotransmitter that has one effect with one receptor, and then the other receptor that binds it has a different effect. One would be on the muscles, one would be on, the digestive system, for example. So remember the three modes are either what? What were they, everyone? Direct activation, which was also called ionotropic, or you can have indirect activation with proteins that could either lead to channels opening or the release of a protein. Yeah. Here are the three different options. If it's direct activation, we have fast synaptic transmission. If it's indirectly opening ion channels, we have a more profound effect, but it's slow. Or we could have the indirect activation of intracellular events. That's where we have like cyclic AMP or everything else that you guys have discussed, where we have sort of processes occurring as a result of the neurotransmitter binding with the third option. Yep, so we'll get, I have a slide for it. I'm surprised you haven't been there yet, Joseph. So let's go through the three again. I just want to make sure that you guys get this. Because neurotransmitter is being released, neuromodulator is being released, there's one of three options that can happen. Direct activation of ion channels. This is where we have the binding of the neurotransmitter to the receptor opens, and then we have ions being exchanged, so we have fast-acting transmission. Binding, opening, release. Oops. Here's metabotropic, and can you see where, I think this is this slide right here, yeah. So with indirect activation, and Hannah was talking about G proteins, when the neurotransmitter or neuromodulator binds to the receptor doesn't open to release ions, it releases a G protein into the cell. So see how in this case, instead of the neurotransmitter binding and causing a channel to open, this releases a G protein. Now this G protein floats on the inside of the postsynaptic cell and then can interact with multiple channels. So it's a slower acting mechanism, but it has a more profound effect. So that's why it's called slow acting. So indirect activations are utilizing the release of a G protein. What happens if the G protein doesn't interact with channels? Then we get our third option of what can happen, the activation of intracellular events. So in this case, we have the neurotransmitter that would be released that would cause sort of like the neuron to do something with its machinery or processing or gene transcription or upregulating something or releasing hormones, something, right? What happens here is it's called the second messenger system, because we have the G protein causing an intracellular process. So it's a second messenger. So here we have Joseph's example. Do we all know what cyclic AMP is for? Energy metabolism. So the release of cyclic AMP is going to tell the body to upregulate its metabolism. So here we have the third option, or the indirect activation. Neurotransmitter binding, G protein being released, except in this case, the G protein isn't being interacting with a channel. It's interacting with this enzyme, adenylate cyclase. This is just an example. So when it binds, it causes cyclic AMP to be formed. So this is the second messenger. This binding has caused this to release another sort of messenger into the body. That's what's called the second messenger system. Does everyone get that? Does that answer your question, Joseph? Jojo? JD? No. So Hannah wants to know this. So this method does not open ion channels. Well, because then whatever's being created would go in and start interacting with different things inside the body. So what happens if it started releasing mRNA for gene transcription? That second messenger, right? It's not a receptor or G protein. It's created something that's going to go into the body and then start causing different things to happen. So it's a messenger that's going to go tell different cellular processes to occur. So for example, with like increased metabolism of a cell, the instinct of all the different organelles and all the other things inside, you would need a messenger to go in and interact with all of the different cellular processes. So you have one binding causing this to create something that will interact with a multitude of different areas. So it's almost like exponential effect. Whereas, so back on Hannah's thing. So here we have one G protein, but this G protein in metabotropic activation is only interacting with one thing, a channel. So it's going around and touching all the different channels and opening them. Whereas in this case, by activating a second messenger, we have our first messenger interacting with an enzyme, as in this example, and then this enzyme is creating a second messenger that's going to interact with a whole multitude of things. Does that help clarify it more? Perfect. Is everyone okay? Awesome. So in that case, you're creating a cascade of different intracellular effects with G protein activations. So indirect activations, they can cause, they're slower acting, but they can cause a whole bunch of different things to occur within the cell, depending on how many things the G protein interacts with. So the G protein can interact with different channels. It can interact with different enzymes that will cause the release of different second messenger systems. So Kyle, I can't do that because then I can't do the group chat. So if I was to make yeah. So this is just reviewing. Yeah, for sure. So this is just reviewing, remember? So we have the binding of a neurotransmitter. What can happen? We could have direct activation or indirect activation. And indirect activation can do all this stuff. Cool. So that was the hardest part of the lecture. Now we're just going to go through different examples of different neurotransmitters. So neurotransmitters are going to be named by the receptors that they interact with. Sorry, the receptors are going to be named by the neurotransmitters that they interact with. So let's talk about the 7 most common neurotransmitters, just to give you guys an example of certain things that you've probably already heard about, but now understanding them from a neuroscience perspective. So have we all heard of acetylcholine? So acetylcholine is the main neurotransmitter of the neuromuscular junction. So the neurotransmitter that is released when you have a neuron, a motor neuron, interacting with a muscle cell is acetylcholine. So it will activate the muscle cell. And so the acetylcholine receptors are going to be the ones that are located on the muscle membrane. There's 2 different types. So here we were talking about how you could have, one neurotransmitter having opposite effects. There's 2 types of acetylcholine receptors. There's nicotinic. So nicotinic receptors also bind or react with nicotine. That's why when you are smoking, you feel like energized, but smoking nicotine, you feel energized in a sense, but your digestion slows down. Does that make sense? Or does anyone recognize that? That's because you have different receptors that will bind acetylcholine. We're going to talk about it at the end of the lecture, myasthenia gravis. Did I show you guys a TikTok about that? But that is a dysfunction or an autoimmune disease of your neuromuscular receptors, so your acetylcholine receptors. Sorry. Glutamate is the main excitatory neurotransmitter of the central nervous system. It can act either directly or indirectly. And it's in more receptor binds to a neurotransmitter. Is there a hierarchy? If more than one type of receptor binds to a neurotransmitter, is there a hierarchy? It's just what is located. So it's not smart. Whatever receptors are located in the area where it's released, the neurotransmitter will just bind. Then let go and bind to another one, and then lock and key. Glutamate is the main excitatory neurotransmitter of the central nervous system. So it can act as either ionotropic or metabotropic. And it's involved in the long-term potentiation, and it's described as important in learning and development because it's excitatory. So it can act as fast-acting, then activation, but long-term effects in terms of modulation, it can act as a neuromodulator, and they think in learning and development. Ironically, or not ironically, sort of interestingly, decreased levels of glutamate are seen in people with depression. So if they think of when you're depressed, you don't have a lot of energy, right? The lack of glutamate, maybe as a neuromodulator, is a reason for that, or sort of a neurological or neurophysiological example or manifestation of that is a lack of glutamate presents globally as depression. With seizures, we see that there's increased levels of glutamate. So if you think people have epileptic seizures, it's like a discharge of energy. We see in those patients, we see increased levels of glutamate. So maybe that's a reason behind it. Too much activation. Sean's still in workout mode. He's thinking about glutamine. Yeah, different. GABA is the main fast-acting inhibitory neurotransmitter of the neurological system. And here's an example of two different types. Has anyone ever taken lorazepam, diazepam, anti-anxiety stuff? So those are all benzodiazepines. So remember, drugs that we take are either going to be mimicking or neurotransmitters, neuromodulators, or they're going to be reuptake inhibitors. So they're going to make sure that the body isn't reabsorbing the neurotransmitters, and therefore making the ones that are available having around for longer, so potentially having a longer effect. Here's an example of how we have one neurotransmitter with two different receptors. GABA A receptors. This is used a lot in anti-anxiety medications and sedation. So barbiturates, benzodiazepines. These drugs are sort of used in anxiety. Baclofen. Has anyone ever had baclofen before? This is a muscle relaxant. So this is more centrally, so central nervous system. This is more peripherally. So the GABA B receptors would be located more peripherally. They will also bind GABA. What about opioids? Have you all ever heard of opium, codeine, morphine, oxycodone? So all of those interact with the perception of pain. So substance P and everything else that's involved in that pain response. So codeine is Tylenol and is the codeine. Percocet is Tylenol and codeine. Oxycodone is anti-inflammatory plus oxy. So it's all they're all just mixed matches of the same sort of opioid mechanism. Dopamine is the main slow-acting inhibitory neurotransmitter. So dopamine is used a lot in sort of motivation and thinking. We talked about the use of dopamine in the basal ganglia, and we'll get more into that in the basal ganglia lecture. Low levels of dopamine are seen in Parkinson's disease. And so that's why with Parkinson's disease patients, where you have decreased activation of the basal ganglia, we are giving them as some sort of like a drug supplement. We give them dopamine. High levels of dopamine are seen in patients with schizophrenia. So they have almost too much inhibition. This is almost a dissociation of the brain. So this is a slow-acting neurotransmitter, right? So low levels, you see jerky movements, as you would see in Parkinson's disease. If you have too much inhibition, that's seen in schizophrenia, you have too much of an inhibition, parts of the brain start to dissociate. So with schizophrenia, where people have a hard time sort of dissociating between reality and non-reality, we see that sort of physiologically as a high level of dopamine in the brain. Yes, because it's also, so Joseph's reading ahead again, the sentence ahead. Dopamine is also used in the reward mechanism. So that's why people take it as a drug. So like cocaine is dopamine. Well, because you're taking it in, right? So you're sort of dissociating your reality and feeling good. So it allows you to think of dopamine is released when we do something as a reward. We're rewarding our brain for accomplishing it. It's a sort of a way to like motivate our brain to do it. We're motivating ourselves to do it. If you're taking cocaine, then you are putting in that reward, right? You get that high of like, oh, I would assume from the Google that you would get, a feeling of you're motivated. You have that reward mechanism, right? So it's not the fact that it inhibits; it's the fact that dopamine is present. No, it isn't inhibiting. It's inhibiting the. Think of it like it would be inhibiting the. Inhibiting the mechanism to say that you haven't accomplished your goal yet. If you have a list of things you need to do, right, and you complete them all, your body releases a reward, right? So it's inhibiting the feeling of, okay, I need to get stuff done. It's inhibiting the bad thoughts so that way you can feel good. Exactly. It's hard. So the problem with all of these neurotransmitters is that they affect so many different areas that it's hard to just label one thing that they do. So to like sort of like discuss like in general what they're doing is difficult because let me show you this one. Let me just show you this one slide right here. I skipped a slide, but when they like do like drug testing or clinical trials, you're taking you're taking a drug that's going to either be a neurotransmitter agonist or antagonist, and then it's like this where there's a bunch of different effects on different parts of the body. So you got to figure out like what areas that drug is going to highlight. So there's such an interplay of what specific neurons that neurotransmitter drug is going to interact with. And dose response, like half-life, like it's that's why there's clinical, that's how the clinical trial method sort of started, right? Because okay, there's a whole bunch of different drugs that can be dopamine agonists, but which ones, depending on how they get into the body, where are they gonna go? Where do they float around with? How long do they stick around, right? Norepinephrine is one that we are, so those last two ones. Norepinephrine is one that we've probably all been familiar with. EpiPens. So when we want a fight or flight response, we are releasing the hormone epinephrine. We can take it supplementarily, where we inject someone that's having an anaphylaxis reaction with epinephrine. So that's going to cause a sympathetic response. So epinephrine or norepinephrine is the neurotransmitter that's involved with sympathetic activation. And so, have you all ever heard of the term beta blockers? Does anyone have heart disease, or their parents or their grandparents? You take beta blockers? So what beta blockers are is that, so you know when you have a fight or flight response, you turn up like sort of like physical stuff and metabolism, and then, or not metabolism, like the fight or flight response, like energy, and then you downregulate digestion. So think of how we have one release of a neurotransmitter, in this case the hormone, and it's going to interact with two different receptors that bind it. Alpha receptors are inhibitory, so they're probably going to cause a release of some sort of inhibitory ion, but these are going to be located on the smooth muscle. So you have one hormone that's going to interact with the A receptors that are on digestion stuff and turn it off. And then you have the beta receptors or the B receptors that are going to be on the muscle and cardiac muscle and are going to be excitatory. So when someone takes beta blockers, they're blocking the epinephrine receptors on their heart, because that would increase heart rate and blood pressure. So if you have high blood pressure, you're taking a B receptor binder so that the heart can not pump as hard, because they already have high blood pressure, those patients. Yeah. Serotonin is for your general arousal level. So when we are alert, you have high levels of serotonin. When you are sleepy, you have low levels of serotonin. So we would see low levels of serotonin when we are in REM sleep, for example. Interestingly, we also see low levels of serotonin, low levels of arousal in those people that are depressed, as well as people that sort of at risk for suicide. Now, I don't know if you guys are all familiar with like Prozac. This works on serotonin level. So Prozac it was an antidepressant that would work with the serotonin reuptake inhibitors. Serotonin is also involved in like sort of like illegal drugs like Molly or like MDMA. I don't even know what you guys call them anymore. So that is a serotonin reuptake inhibitor. So what that is doing is like adding serotonin to the body. It's increasing arousal level. Karen's asking a question. What do you mean? It's so then your body just makes it and then that's it? No, your body is constantly making them, breaking them down, making them, breaking them down. Every time a neurotransmitter is released, it doesn't get pumped back in. It gets pumped in, broken down, and remade. Because one thing that you guys don't realize is that as it's released and the more time it's spent in the extracellular space, it starts to break down and wears and tears, just like any sort of physical thing. So your body takes it back in, breaks it down into all the different component proteins, and then puts it back together. There's no max, no. Yes, exactly. So let's look at a video. This is the next coming slides. Yeah, so Joseph was talking about adrenaline. That is like adrenaline. That is epinephrine. So I would say, so Carl and Joseph and everyone. So Carl is asking, so the terms like norepinephrine, noradrenaline, epinephrine, adrenaline, they're all kind of interchangeable. They are all in the same family of the same base neurotransmitter. So they're so then they would all have different tails, or they're a little bit different, but all in the same family. Does that make sense? So as I presented in this lecture today, so a lot of the common drugs that we are familiar with, they're either actually neurotransmitter agonists, or they cause an increased effect of the neurotransmitter, or antagonists. They would cause a decreased effect of that neurotransmitter. If something is a neurotransmitter agonist, so if I take a drug and that's a specific neurotransmitter agonist, it's either creating more of that neurotransmitter or stopping the reuptake of it. Whereas if it is the drug that I'm taking is a neurotransmitter antagonist, it's either breaking down the neurotransmitters or blocking the receptors or blocking the binding of that neurotransmitter. Does that make sense? Yeah, so then that would be an antagonist. Yep. So Karen's like, what about if there was an increased reuptake? So that would be an antagonist. It's removing neurotransmitter from the synaptic cleft or from the body. Is everyone okay with that? I kind of feel like I was a bit all over the place on this one. Anyone that hasn't talked yet, are you guys okay with the delivery method of this particular lecture? There's been a lot of talk in the group chat, what I personally like. So as long as we're all okay and learning, and it's all good. Okay, sweet. I like when you ask questions, because any of you can just read the slides, right? But now you realize that from my midterms, if you just read the slides and are familiar with it, then you're fine. But if you want the interaction to help foster learning and you need more of a back and forth, then this is what the lecture's for. Yeah, so Carl, so that's pharmacology. Yeah, you guys do a pharmacological class? That's great. But yes, exactly what Carl's saying, how everything's interlinked, right? So Karen or Keenan or whoever wants to ask or answer, Hannah maybe, what is the acetylcholine receptor? Where would we find that? So acetylcholine was what neurotransmitter? Right. So that is involving the neuromuscular junction. We have our acetylcholine receptors on the muscle cell, and it's going to bind the acetylcholine that's being released from the motor neuron to cause activation of our muscles. So it is the main neurotransmitter of the neuromuscular junction, and it's implied in myasthenia gravis. Myasthenia gravis is an autoimmune disorder that attacks the acetylcholine receptors on our muscle cells. One thing about neurological diseases is that a lot of them are autoimmune disorders where we have our body breaking down itself. And myasthenia gravis is an autoimmune disorder that specifically attacks our acetylcholine receptors. And so if we had a lack of acetylcholine receptors, what would be some sort of think it out, what would be some clinical sort of things that we would expect in terms of symptoms? If we had a decrease in the use of our acetylcholine receptors, what would happen? Yep. Then it's saying slower muscle activation. Yeah. Because if we don't have similar structure, yep. Weakness. Because if we don't have our receptors, so think of it this way. If we don't have the acetylcholine receptors on the muscle, that means that you're releasing acetylcholine, but there's nowhere for it to bind. So then the muscles won't contract. So we would get weakness, these stroke-type symptoms that Shane's talking about, what Hannah says, slower muscle activation. Here we have drooping eyelids, a sort of facial expression, problems breathing and swallowing. If we have issues with sort of the neuromuscular junction, we tend to see the finer effects on our fine control because it requires more finer activation. So that's why we start to see it on the face. So here we have an example of a young woman with, I don't know if you guys can see this, but hopefully. This is an example of someone clinically with myasthenia gravis.
It's the 19th of December 2013. Lara is going to describe the symptoms of mycemia she's experiencing today. I will run through them very quickly because her speech is affected and it's difficult to hear her. So the first thing she'll try and talk about is her eyes. These stop, she can't really close them very well. Then the facial muscles, especially those around her cheek, become paralysed. Her tongue also becomes progressively more paralysed. Swallowing is very weak. Neck muscles also are very weak. Although this is not happening today, at times her breathing will feel slightly compromised. Okay, over to you, Lara.
Okay, so first of all, my eyes. I can't strain them out tightly or close them, particularly at night. So, for example, it's really trying my hardest to screen them up, but they're very easy to open. Just by like washing my face, things like that, I can get water in my eyes quite easily. Secondly, my cheek muscles around here, I find it quite hard to do facial expressions because they just don't move around here. Then it's my tongue, which affects my pronunciation. So it can be difficult for this in turn affects my swallowing. So liquid goes up my nose and it's quite hard to swallow. Then obviously I get the neck movement around here. And it can affect
breathing. Okay, so as you can see, as Lara starts to talk, it becomes far more difficult. This is about as bad as her symptoms have got. With a few moments recovery, she's usually able to start talking again, but especially if she relaxes and she's a bit uptight, so it probably won't come back as quickly. But if you try and describe your swallowing part again now, see if that you can say.
So my swallowing gets quite weak, and I find it difficult because liquid goes up my nose. So it's words like with an N, my nose, and breathe.
Right, and breathing can be affected. Right, stop again. Right, Lara has just begun pulse treatment again, which hopefully in the next few days will kick in and her symptoms will be relieved for a few weeks.
Any questions about that video? Oh, did you, Hannah? So you guys did a case study about this. So did you see how like she was able to talk for a little bit and then she couldn't? It's because there was only so many acetylcholine receptors available because there's less, right? Their body's fighting it, or her body is breaking them down. So then a little bit of use, and then all of a sudden all of the acetylcholine receptors are already being used up. Pulse therapy that I mentioned in the video, pulse is like high dose corticosteroids. Just to like remember, the corticosteroids would help stop the sort of inflammation reaction in your body affecting the attacking of itself. Yeah, because it has such a profound effect. So Sean's saying how it's just interesting to see the effect of the fatigue of muscles on the face. And can we all understand why it would be more profound on the face than her hands and limbs because of the fine control required? Remember, from the motor homunculus, and fine control, hands and face. The face muscles are a lot smaller, so therefore, just because they're smaller, there's going to be less acetylcholine receptors. So it would affect the whole body. It depends on where sort of the inflammation or the neuroinflammation is most affecting. Okay, so Shane has a question. You tell me. So he's asking if this would be just for sensory or motor. Well, there would be no. Where would the acetylcholine receptors in the sensory system be? Because the neuromuscular junction. So it's just motor. Just because they're not like if there was acetylcholine receptors on something sensory, then it would affect it for sure. But do you see the difference though? Totally honest question, but that's why. And then Joseph asked something. Oh, if the receptors get if the receptors get destroyed, the neurotransmitters they just float in the synaptic cleft, and then it's a time thing, and then they get taken back in without ever being used. In terms of treatments for myasthenia gravis, you could do neuroinflammation stuff, anti-inflammatories. That was the pulse therapy, so corticosteroids. Do you guys remember what plasmapheresis was? Plasmapheresis was when you filtered out the blood. So you take out the blood and you're filtering out the antibodies. Oh, I'm sorry. I missed a question. Yep, you guys are all right. So I missed one, like an oil change out. Arvin is asking what are corticosteroids. So steroids are a way to stop inflammation. So cortisone. Has anyone ever taken cortisone shot? Oh, I hurt my shoulder. I gotta get a cortisone shot. It's corticosteroid, which would decrease inflammation in that area. The inflammation reaction. So if you take a whole bunch of corticosteroids, you are decreasing the inflammation reaction sort of systemically. In this case, it's important because the risks of because inflammation is good in a sense, right? But you're decreasing the effect of the myasthenia gravis at the risk of potentially getting the inflammation, decreasing the good effects of inflammation for the rest of the body. Oh, so Sherry just got a cortisone shot in her thumb. So it's decreasing inflammation, right? If you take it for full body, then you would be helping with the sort of inflammation, neuroinflammation that's causing the MG for the people. Thymonectomy, so our thymus is what is involved in the immune system. So that's why removing the thymus would be a way to decrease the inflammation reaction of the body. Yeah, no worries. Any other questions? How was that today? Not too long of a lecture. Okay, great. Any other questions, anyone? I'm going to stop recording and then we can. Good.